Okay, so we can start. I think this summer, most of us have focused our attention on the London Summer Olympics with its wonderful opening ceremony featuring the Queen, James Bond, and Mr. Bean. If you look closely at the logo of the London Olympic, you can find hidden in it is the letter I, the letter T, and also the letter P. So this is also the year of ITP. And this is the main reason I was asked to give this presentation. Interestingly, the performance of some of the Olympic gold medalists are closely related to my presentation today. And I hope at the end of my presentation, I can show you the connection. Traditionally, immune thrombocytopenia is thought to be a disease characterized by accelerated destruction of platelets by the anti-platelet antibodies. Treatment is therefore primarily directed at reducing destruction of the antibody-coated platelets. Steroids is usually the first line of treatment. For patients who failed corticosteroids, a number of treatment options are available. But unfortunately, many of these so-called second-line treatment options are like the measures that some countries use to handle the economic crisis. They are either ineffective, have only temporary effect, and are associated with a lot of side effects. For example, during an economic crisis, some countries, like Greece, the United Kingdom, may try to cut the budgets, cut jobs, cut social benefits, cut pensions, cut social public service, etc. Similarly, in ITP, some of us may try to cut out the patient's spleen. Just like many people do not like having their social benefits cut, many of the ITP patients are reluctant to have their spleen cut out. Some countries, like the United States, practice quantitative easing and inject billions of dollars into the trouble bank or trouble industry. Similarly, in ITP, some of us inject the patient with IVIG, but these are costly and at best have only a temporary transient effect. All of us have encountered refractory ITP patients who have failed many lines of treatment. And the only thing in the past we can do for such patients is to pray. We pray to God that such patients, despite having a platelet count in single digit, would not have a fatal bleed. But unfortunately, such prayers are not always answered. The best way to handle an economic crisis is actually to create jobs and stimulate productivity. Similarly, in ITP, there is now evidence that the serum thrombopoietin levels are inappropriately low or only slightly elevated. Therefore, stimulation of platelet production by thrombopoietin mimetics may be especially useful in patients not responsive to current available treatment. Two agents, or two thrombopoietin receptor agonists, have been licensed for the treatment of immune thrombocytopenia. One of them is eltrombopag or Platelet, which is a small molecule non-peptide thrombopoietin agonist. Unlike native thrombopoietin, which will bind to the extracellular region of the thrombopoietin receptor, eltrombopag, on the other hand, will bind to the transmembrane region. Following binding, it will activate intracellular signal transduction and stimulate platelet production. The other thrombopoietin receptor agonist that have been licensed is vomiplostim, or Nplate. It is a fusion protein consisting of the constant region of the immunoglobulin molecule as well as a thrombopoietin receptor binding domain. Like the native thrombopoietin, it will bind to the extracellular region of the thrombopoietin receptor. Unlike eltrombopag, which is given orally as a single daily dose, romiplostim is usually administered weekly as a subcutaneous dose. Numerous clinical trials have been conducted to test the safety and efficacy of eltrombopag and romipostine in patients with chronic ITP. This includes phase 1 dose-finding trial, phase 2, phase 3, and even open-label trials. If you summarize all these clinical studies with these two drugs, they usually include ITP patients of at least 6 months duration. These patients usually have failed at least one or more prior ITP therapy. Over 1/3 of them has splenectomy. Most of these patients have a baseline platelet count of less than 30,000 at the time of entry into the study. And if you combine all these studies, you can see an overall response rate of about 60 to 90%. And the drug is usually well tolerated with a good safety profile. In the typical responding patients, you can see that the platelet count usually starts to increase after 1 week of treatment and then peak after 2 weeks of therapy, and they are usually maintained as long as the patient continued on the drug. But following stoppage of the drug, the platelet count usually drop back to the baseline level, but no worse. The improvement in platelet count is usually accompanied by a significant decrease in the bleeding symptoms. Again, following stoppage of the medication, the bleeding symptoms return to the baseline level, but no worse. Based on this observation, usually when we start a patient on thrombopoietin receptor agonist, we usually wait at least 3 to 4 weeks before we decided that the patient failed to respond to a given dose and then contemplating adjusting the dose or switching to another medication. Similarly, should the patient develop severe thrombocytosis while on therapy, when you stop the drug, the platelet count usually will return to a normal level or safe level within 1 to 2 weeks of discontinuation. The drug is able to reduce the use of concomitant ITP medications in about 50% of the subjects. In this study, the RAISE study involving eltrombopag, you can see that significantly more patients, about 60% of the patients in the eltrombopag group, were able to discontinue concomitant ITP medication such as steroids or cyclosporin, etc., as compared to about 30% in the placebo group. But if you look at the data from another angle, that means significant proportion of patients required both thrombopoietin receptor agonists as well as other ITP medication in order to get or maintain a satisfactory platelet count. This is not surprising because ITP involves both platelet destruction as well as decreased production. And in some patients, you need both drugs that stimulate production as well as drugs that reduce platelet destruction in order to maintain a response. Similar response were observed irrespective of the splenectomy status, as shown here. Whether patients have splenectomy or not, similar proportion of them respond to thrombopoietin receptor agonist with a similar time profile. Thrombopoietin receptor agonist has also been shown to significantly increase or improve the patient's quality of life. And as shown here, there is significant improvement in physical function, physical role, emotional function, etc. for patients taking eltrombopag. Similar observations were seen also with romipostine. And in some single-label long-term extension study, for example, in the EXTEND study involving eltrombopag, over 300 patients have been followed for a median of over 2 years, with nearly 10% of the patients followed over 4 years. And you can see that nearly 90% of the subjects achieved and still maintained a response to eltrombopag up to 4 to 5 years on the drug. And again, similar response was seen irrespective of their baseline platelet count, whether they had splenectomy or not, and whether they are taking concomitant ITP medications. In 2 long-term extension studies involving romipostine, again, you can see that between 65 to 90% of the patients, again, have long-term response. How about long-term safety issues? Actually, some of the potential safety issues or uncertainties regarding this class of drug can be summarized with the word TPORA, or thrombopoietin receptor agonist. T stands for the risk of thromboembolism. There has always been a worry that this class of drug, by increasing the platelet count, may predispose ITP patients to increased risk of thromboembolism. About 5.1% of patients treated with eltrombopag experience about 30 thromboembolic events. If you look at it, deep vein thrombosis was the commonest, followed by pulmonary embolism, myocardial infarction, and ischemic stroke. If you compare that incidence of 5.1% with the overall incidence of thromboembolic event in the general ITP population not taking eltrombopag or thrombopoietin receptor agonist, you can see that according to the United Kingdom or the US database, between 6.1 to 6.9% of ITP patients not taking thrombopoietin receptor agonist experience thromboembolic event. Therefore, the 5.1% observed with eltrombopag was no higher than that reported with the general ITP population. Moreover, there was no association between the maximum platelet count and the occurrence of the thromboembolic event, as shown in this figure. On this side, on the left-hand side, is the maximum platelet count experienced by the patient. On the right-hand side is the platelet count at the time of the thromboembolic event. You can see that only in 3 subjects, the thromboembolic event occurred at the maximum platelet count experienced by the patient. For the majority of them, the thromboembolic event occurred at a platelet count much lower than the peak platelet count. In half of them, the thromboembolic event occurred at a platelet count below 150,000, and in 1/3 of them, the thromboembolic event occurred with a platelet count below 50,000. Also, all the patients who had experienced thromboembolic event had at least 1 or more risk factors for thromboembolism, such as prolonged hospitalization without prophylaxis, smoking, hypertension, etc. Also, the median time from the treatment with thrombopoietin receptor agonist to the occurrence of the thromboembolic event was around 230 days, ranging from as short as 1 day while the patient just started on the drug to over 2.5 years. That means in some patients, the thromboembolic event occurred with a platelet count less than 10,000 shortly after the patient took the drug, and others, it occurred after the patient had a stable platelet count of around 50 or 100,000 for many years. The fact that there was no relationship with the maximum platelet count, no relationship with the duration of therapy, and all the patients have underlying risk factor, and the overall incidence was no higher than that observed with the general population, the data so far did not suggest an increased risk of thromboembolism with this class of drug. But nonetheless, with patients with a lot of risk factor for thromboembolism, we still advise using the drug very cautiously, starting with a low dose and titrating the drug to a minimal platelet count to stop the bleeding. P stands for pregnancy and pediatrics. In laboratory animals, only at very high doses, there was increased fetal loss, but there was no fetal loss or effect on the fetus at much lower doses. But nonetheless, data in humans are lacking, and this class of drug currently was not recommended for use in pregnant women. There are a number of clinical trials studying the effect of this drug in pediatric population. The initial data are encouraging, but we still need longer follow-up and more data. And currently, the drug again is not recommended for use in the pediatric population. O stands for off therapy. There is always a curiosity whether the patients need to be on thrombopoietin receptor agonist indefinitely, or some patients can be off the drug after a short period of treatment. If you look at the extent study, you can see that about 4.3% of the subjects, 13 out of 301, the patients are able to discontinue eltrombopag and have a platelet count of well over 50,000 more than 1 year after discontinuation of eltrombopag. These patients have chronic ITP. Average duration since diagnosis was over 2 years, and they have been on eltrombopag usually for over 6 months, but in some patients, a short course of eltrombopag results in a prolonged remission. Therefore, all I can say is prolonged remission of therapy is possible in a minority of patients after taking eltrombopag or thrombopoietin receptor agonist. Actually, similar observations were seen with romipustin. You may ask why. In the laboratory data, this class of drug has an effect on the regulatory T cells, and it may be one of the reasons or mechanisms why some patients are able to have a prolonged remission of therapy. R stands for reticulum formation. There is always a worry that this class of drug may stimulate proliferation of fibroblasts and increase the risk of myelofibrosis. If you look at the extent study, 147 on-treatment bone marrow biopsies were performed on 135 patients and have been treated for eltrombopag for a median of over 1 year. Majority have myelofibrosis grade 0, some have myelofibrosis grade 1. Only 8% of the population have myelofibrosis grade 2. None of them have myelofibrosis grade 3. And for those patients who demonstrate myelofibrosis grade 2, none of them had any abnormal hematological pictures, abnormal cytogenetic or molecular abnormalities. 11 patients have a second biopsy. 8 had no progression. 1 experienced a change from grade 1 to grade 2. But on the other hand, 2 experienced a decrease from grade 2 to grade 0 or to grade 1. Therefore, so far with the limited follow-up, there was no evidence that eltrombopag increased the incidence of myelofibrosis. Similar observations were observed with Nplate or romipustin. A stands for the most important concern about this class of drug. It stands for affordability. This class of drug is very expensive, and for eltrombopag in Hong Kong, it can cost up to $700 per month, based on a 25 to 50 milligram daily dose. Unless the drug is reimbursed by the government, for many patients, it will be an absolute financial contraindication. And for some of them, after they have taken the drug for a while, it may be intolerable financial toxicity. There is one complication that was observed slightly more common with eltrombopag as compared with romipustin, namely hepatobiliary laboratory abnormalities. If you look at all the eltrombopag study, you can see that approximately 10% of the subjects experience elevation of liver enzymes or elevation of bilirubin while taking eltrombopag. But fortunately, for almost all of these patients, these hepatobiliary laboratory abnormalities were transient. They resolved spontaneously while the subject still continued on the drug or shortly after discontinuation. And there was no evidence of any irreversible damage of any clinical significance. Therefore, we suggested that for patients taking eltrombopag, you should monitor the liver enzymes periodically. If they have a mild elevation, in most cases, you can continue the drug and they will resolve spontaneously. But for those who have continued increase, then stopping the drug, in most cases, the abnormalities will resolve. We have patients that have abnormalities, we stop the drug, and then we re-challenge with the drug, and those hepatobiliary laboratory abnormalities did not recur. This is a summary of these two classes of drug, and as you can see, Okay, if you look at overall efficacy, ability to reduce concomitant ITP medication, reduction of bleeding symptoms, incidence of thrombosis, incidence of fibrosis, etc., the two drugs are almost identical or highly comparable. Which one you prefer is also basically a personal choice or the patient choice. And according to the ASH guidelines, thrombopoietin receptor agonist is now recommended as second-line treatment for patients who have failed or relapsed after splenectomy. And in Hong Kong, this is our treatment algorithm for patients with ITP. For patients that require treatment, steroids is still our first choice. For patients who have failed steroid, splenectomy is still our top second-line treatment. But for patients who have failed or relapsed after splenectomy, who refuse splenectomy, or in-home splenectomy is contraindicated, thrombopoietin receptor agonist with its efficacy and safety profile is a reasonable alternative. Finally, the connection between the performance of some outstanding Olympians and my presentation today. To many of us, the performance by Michael Phelps, his record gold medal hold, is the top rating in this year's Summer Olympic. If you take the statement, to many, Phelps is top rating. You take the letter in red and rearrange it, it becomes the word Tpor agonist. You take the letters in purple, it is the word help. You keep the word many, and you take the remaining letter in green, it becomes, thrombopoietin receptor agonist help many ITP. Thank you.
Thank you very much, Professor Cheng, for your stimulating and convincing lecture for us. I think that since the next topic will be a different issue, we can open and you have a few minutes for the question. Professor Surapon, please.
So when you get the increased platelet count after eltrombopag, is it possible to lower dose in order to maintain?
So what we usually do, we start the patients on eltrombopag, and then we observe, the response. We usually aim at the platelet count just above 50. That will be our target. Once we achieve, this target platelet count, we will first attempt to discontinue the concomitant ITP medication if the patient is also taking cyclosporin, steroids, etc. After we taper the patients off all concomitant ITP medication, then we will gradually adjust the dose of eltrombopag, usually every 2 to 3 weeks, to the lowest amount able to maintain a platelet count of over 50. In so doing, we have patients that are taking maybe only 25 milligrams of eltrombopag daily. We have a certain percentage of patients taking 25 milligrams on alternate days. We have patients taking even 25 milligrams 3 times a week. And if the patients have a stable platelet count on this so-called minimum dose for 3 or 4 months, we attempt to discontinue eltrombopag completely. And we were able to have a few so-called prolonged response of the drug. Should the patients relapse after we discontinued eltrombopag, the majority of them will respond after we introduce the drug to the previous responsive dose.
Yes, please.
Can you predict who are the patients who would respond to these agents or not respond to these?
So far, no. We have looked at pre-treatment platelet count. We have looked at bone marrow cellularity. We have looked at megakaryocyte number, pre-treatment from thrombopoietin level. None of them were predictive of response.
Okay. My second question is, that this eltrombopag use has been seen in patients with aplastic anemia.
Yes.
So in your trial, have any of the patients, have you looked at whether there was an increase in hemoglobin or the white cell count in the ITP trial?
Actually, in most of the ITP patients, for them to enter the study, they should have or they must have a normal hemoglobin or a normal white cell count, okay, before enrollment in the study. I can only say from my personal experience, we do participate in trial of patients with MDS or in trial of patients with aplastic anemia using Eltrombopag. And we did observe in a couple of cases improvement in all three lineages, in both patients with MDS and aplastic anemia.
Any more questions? If not, since the time is running out, I would like to thank Professor Cheng for your talk. Thank you.